This week on the BackTable podcast.
I always thought type 5 was some hocus pocus because it never made sense to me. I read it in books. I haven't seen it personally, but it's good.
I've seen it. I drained it, and it's real. So
really, all right.
Yeah, you're much older than you. So
no, I'm glad to know. I always called it. I called it the idiopathic endotension.
Yeah. It is. It's there. I mean, just put a needle and you just get fluid back. Shooting.
So crazy. Interesting.
Yeah.
Welcome back. This is part 2 of the Endoleaks episodes with guest host Sabeen Dhand and guest Saher Sabri.
Hello, everyone, and welcome to the BackTable podcast, your source for all things IR and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. This is Sabeen Dhand as your host this week, and I'm very excited to introduce our guest today, interventional radiologist Dr. Saher Sabri, coming to us from MedStar Georgetown Hospital. Welcome, Saher.
Hello, welcome, Sabeen. Thanks for having me.
Of course. Well, before we dive into our topic today, just want to say a quick word from our sponsor, RadPad. RadPad was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RadPad radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information. Contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. Let them know you heard about it on BackTable podcast. And let's delve into our topic. Well, let's talk about approaching these type 2 endoleaks. There's 4 major ways. When you schedule these patients to be treated, do you do it under general anesthesia or do you do conscious sedation?
Depending on the patient, most of the time it's sedation. If I do direct sac puncture on an elderly patient and have that discussion with them, and most of the time I do it with anesthesia available, but they rarely intubate the patient. So
yeah,
I generally speaking do it with sedation, but I've had these translumbar access and then direct sac puncture, and patient not being tolerate being on their stomach, and they move on you, and you have a needle in their back, and it's not a good sign.
I know, totally.
For the direct sac, I would do it for the others, for the other ways, not necessarily with anesthesia.
Completely agree. You talked about direct stick. So what's your technique? I mean, do you direct stick the patient under CT and bring them to fluoro? What do you do? How do you first start your direct stick procedure?
The access is, and you alluded to 4 different ways of access. And one of them is a direct sac puncture. There's a transarterial way of doing it. And there's a transcaval way of doing it. And there's a going around the graft, which is something that I want to learn some more tips from you. So these are 4 main ways to do it. So the direct sac puncture is, I usually do it under fluoro. And the way I like to do it is I study the CT very, very well to look exactly where what I call the nidus, the area that is most in the biggest collection of contrast into the sac. And, you see that usually on the later phase. So that's the area you really want to hit. And then you kind of triangulate and see where that is located in relationship to the, iliac limb of the graft, the floor divider, which is the area where the graft separates into 2 limbs, and then the vertebral bodies. And you try from that to kind of draw a line from the skin into that area on the CT. So then I know I need to go at, L3 level at the spinous process, 7 centimeters to the left is where I'm going to start. If I just go 45-degree angle, aiming for the contralateral gates, then I should be able to hit the leak. So there's a lot of pre-planning that goes into it, and that's what I usually prefer to do that under fluoro. I've not needed to use CT for access, but definitely I've used cone beam CT on the table to kind of help guide me through the process, to confirm that what I went through, did I go through a kidney or something, or did I, miss it completely before I go ahead and upsize my access. But that's usually my, triangulation process. I feel like moving a patient from CT to fluoro, although we have rooms right next to each other, I just find it too cumbersome. And I think as interventional radiologists, we have good triangulation skills, and I think we should put it to work.
Exactly. Yeah. I mean, moving that I've never actually done that, moving the patient from CT to IR for this type of approach. I just do it exactly like how you say, and use cone beam. Some people say they've used, some of the special guidance systems on their fluoro machine, like, needle guidance or expert guide. I've never done that, but I think that's a cool way of doing it too, if you want. But I think with our triangulation techniques, we can do it without that. But
I think using these technology, if it's available to you, works great. I've used it before. I think it works very well.
Yes.
You just have to kind of have a, cooperative patient and to be able to kind of match, and have the algorithm work for you. But it works out very well. So, the next thing is, whenever you get this access, it's always the question is, what do you use for access? I usually need like a Chiba needle, INRAD, or one of these needles. And then, what do you, upsize to treat them? Kind of interested to see what do you use for these?
I use an AccuStick, and then I put the AccuStick, into the direct sac, and then I'll use like a 4 French catheter to direct, and then a micro catheter. That's kind of my system that I've done. I've put a sheath in too, if I know I'm going to be pretty successful in the procedure, 5 or 6 French, but I've done pretty well with the AccuStick. And then I definitely do all my work through a microcatheter. I'll inject the nidus. And when you inject the nidus, what are you looking for?
Yes. I mean, I think I've used a similar system to yours. Sometimes I've had, for a small leak and if I hit at a bullseye, I could embolize through the needle.
Yes.
Just put the, liquid embolic through the needle itself, without needing to upsize. So that has, worked actually a few times, depending what you're treating and how big it is. Usually if you identify so usually when you go in and you hit the nidus, you inject, you want to make sure you're in the nidus. Because if you're in, access the sac and then you inject and you see this kind of the area that looks like thrombus.
Blobogram.
Exactly. And you're not in it has to have smooth edges to know that you're exactly in the, in the leak itself, in the nidus, so to speak. So if you're in the, thrombus, it's not, you're going to put a wire, you're going to just make, just dig a hole, basically. You're just going to keep, creating false channels and you're not going to get, you can put a ton of coils or whatever you're going to put in there. It's all useless. So you just have to kind of redirect till you have a drip of blood. I don't necessarily, measure pressure, but I want to see like an arterial flow coming through. If it's like really pushing a lot of blood, like shooting blood, then I'll just measure pressure. And if it's like similar to the arterial, then I know probably I have a type 1 endoleak on my head, not a type 2. And that's something to keep in mind. But generally speaking, I don't necessarily measure pressures or transduce. So basically look for the basic return. Like when we get arterial access in the femoral or radial, you just kind of, wait till they get that blood return. And you want to see this, and it has to be significant drip. So once there, then I just do the same thing as you upsize and such. And then I do an injection. And the idea is to see can you see the outflow? So you're not going to see the inflow, but you're going to see the outflow. If the outflow is a lumbar, that'll be good. You can try then to use, the methods you just mentioned, using a catheter combination, a 4 French and a microcatheter, and go out and try to cannulate these lumbars and then see if you can coil them and then come back into the nidus and then fill the nidus with your choice of, coil, glue, onyx, whatever you want to do. But to go and take out these outflows would be good. Now, if the outflow is an IMA, so the stakes are higher, because if you start putting liquid embolic in the sac, it's going to shoot out of the IMA to the left colic and you have problems. So if the outflow is an IMA, then I would just spend as much time trying to cannulate the IMA through the direct sac access to coil it before going ahead and doing anything. And, if I cannot, then we may have to abandon and consider doing a transarterial access. And that's why I'll go over my algorithm is I usually like the transarterial over the direct sac access for this particular reason, if I think the IMA is patent. But that's generally speaking my thought process. That's what I'm looking for in the end, when I inject the sac or the sacogram, if you may. I'm just kind of curious to see how successful we've been trying to cannulate some of these arteries, the outflow arteries, through the direct sac access.
Very hard. You're going from prone position, your needle's directed anteriorly, and you're basically pulling 180s on the area. It's hard. Yeah, like you said, if you see it, and if the lumbar is the outflow, then just go with the liquid embolic and try to push it out into there. It's generally more easier than trying to cannulate and coil. But I'll try that first all the time. Now, you brought these words inflow and outflow, and I think someone who's starting to treat endoleaks really has to understand that concept. It was something that I didn't really have a full grasp of when I first started these, and you can get into a lot of trouble. You mentioned one. You don't know that means that the IMA is an outflow. You could get into some horrendous complications here. So it's important for our listeners to understand inflow, outflow. I think you described it pretty well. How to, you can do it again. How do you determine what's inflow or outflow on your sacrogram?
Yeah, I mean, I think it's harder, but generally speaking, the endoleak to persist, you need to have an artery that goes into the sac and an artery that goes out of the sac. So it could be one in, one out. It could be, 2 inflows, 2 outflows, and so on. So, and it could be, 3 inflows, 3 outflows. It just depends on how complex the endoleak is. And sometimes you can know what arteries are involved from the CT, but you don't know the direction of the flow. So if you're in the aneurysm and you inject, whatever you're going to see wash out through is usually the outflow. So this is, that this is where the flow is coming out. And then that there's inflow is coming from somewhere else, and it could be the lumbars, it could be the IMA. It's hard to know. That's why I usually prefer to go transarterial over a direct sac puncture. I feel like I can have more control of, I know I'm entering the sac through one of the arteries. So I know I entered, I at least have one in my pocket. I know I can treat this one that I'm in. And from there, I can have a better idea when I inject, I can see where things are. And if I need to coil a lumbar or something, I'm coming, and you alluded to this, I'm coming from an anterior approach, which is the IMA. And I can go, it's easier to select the lumbars if you need to. Or if you're coming from the lumbar arteries, and you can easily go anteriorly and go into the IMA. So I find that my go-to method is usually to go transarterial to treat these, and before I go to the direct sac puncture in general. And we could probably need to, hit on that at some point to go through the techniques of doing the.
Yeah, that's actually the next one I was going to ask you about. So what does transarterial mean? I mean, aren't you in the arteries all the time? What does transarterial mean?
I mean, I think basically you start your axis from the femoral or from the radial. So basically you don't access the sac. You do it like an angiogram, like we do everything. And then, you study the CTA, and then you decide what artery I'm going to go after. I look at the IMA. If the IMA is patent and the endoleak, there's a puddle of contrast that's sitting at the origin of the IMA, then I know the IMA is involved. I don't know if it's an inflow or an outflow, but I know it's involved. That's the case, then I will go from the SMA to the arc right into the IMA. So that'll be the way. And once you're in the sac, you inject, and you'll see if the contrast comes back of the IMA. This means the IMA is an outflow. If you inject and then you feel lumbars or you feel other branches, then you know that the IMA was the inflow. Then you go to embolize your sac the way that we just described earlier. The other approach is, if I do not see an anterior component and I do not see the IMA definitely open, and I see like a big chunk of calcium, or if it's like there's no contrast in it, then the other option is to go through the lumbar arteries. And the way to do this is through the internal iliac artery up the iliolumbar, which is the first branch of the posterior division. We put a microcatheter there and do an injection to see the lumbar arteries fill, and then you get the microcatheter all the way through that back into the sac. And again, you do it the similar way. Usually these would have a paired lumbars, one inflow, one outflow, and you embolize it this way. So that's generally speaking how, I do I choose which transarterial axis I go through. What's your go-to? Do you like to go IMA first, or do you like the iliolumbar,
I like the IMA because I know exactly, if it's open and you do the angio, you're going to see this huge, your arterial and a drum end. You'll see the whole loop, and it's pretty easy to get through relatively, depending on the SMA. So, the iliolumbars I find much tougher. They can be a lot more tortuous. And so my preference is going to the IMA and then doing a sacrogram from there. Is that your thing too?
Yeah, I mean, I think it's but a lot of times the IMA is not just now open, and the top two Endoleak you have is just lumbars in, lumbars outflow. Both are inflow and outflow are lumbars at two different levels or at the same level, and the IMA is out of the equation. And all the leak you see it is all posteriorly. There's nothing anteriorly. If that's the case, your options are direct sac puncture or going through the iliolumbar. I feel direct sac puncture, you go in, you can put some material, and if you don't fill the actual lumbar inflow or outflow, it may recur. And that's where people keep, talking about Endoleaks as like a whack-a-mole. You go and you embolize and it just comes back again. Because if you just embolize part of it, it's not going to solve the issue. You really need to try to hit the actual inflow and outflow and try to hit what's in between, which is the nidus. It's not enough to embolize the artery itself. It's not enough to embolize the lumbar artery. I can tell you that a lot of the referrals I get from the community are somebody went into the iliolumbar and then coiled the iliolumbar. And that's it. Basically, you block our way.
Oh, no. Yeah.
You have to go back to coils or find other iliolumbars. So you cannot just coil the artery. You cannot just coil the IMA. Like if you made all this hard work that you just mentioned to go around the arc, to go to the IMA origin, and then some people just end up just coiling the IMA instead of going into the nidus itself, into the sac, filling the sac itself, and then embolizing the IMA on the way out. I mean, that would be the approach.
Totally. And again, though, one thing you have to be careful. I saw in one M&M conference I went to is an operator went through the IMA and didn't recognize that the IMA was the outflow, had used glue in the sac, and all the glue came out into the IMA and into the colic, and that was not a good complication to have. So again, got to keep in mind inflow, outflow, but when you're doing these. Do you use like 150 centimeter length catheters? That's usually enough?
Yeah, I mean, I think so. I mean, there's a few technical things I'm interested to hear from you, some technical aspects. So, for the SMA, IMA, I try to kind of get a catheter into the middle colic as deep as possible. I'll start with like a Simmons 1, and then I get a microcatheter and try to slide the Simmons over the microcatheter into the middle colic as deep as possible.
Yeah.
And it gives support, and then goes a 150 microcatheter all the way into the sac. For the iliolumbar, I think you end up going ipsilateral oblique. The ipsilateral or very axis, because you cannot go up and over. So you have to kind of choose either right or left, depending which lumbar look more prominent on CT. And then you go, I usually use something like a rim catheter, and then I take it into the gluteal, basically the superior gluteal, and then I pull back and try to hook the iliolumbar with the actual rim catheter to give you some support. And then from that, I put a microcatheter and usually end up, I think a 135 is usually long enough, to get, from an ipsilateral approach to get you what you need. But usually you need something like a 2.0 microcatheter to navigate through some of these tortuous iliolumbars.
Yeah, they're really tortuous too. I mean, if you have access to any neuro equipment too, some of the neuro microcatheters are really great and obviously compatible with liquid embolics. So yeah, but I agree. I'll use a 2.0 Pro grade or something and 150 or 135 length, exactly like how you do it.
The one pro tip, which I know, Sabeen, you do it a lot because you do a lot of CLI, and when you do a pedal loop, when you try to kind of get through some branches that there are a lot of other collaterals, one thing to do is to knuckle the wire, whatever wire, like a fathom or something, or transcend, and then you knuckle it, and that will usually go through the iliolumbar easier than trying to kind of go with the tip of it. Usually we'll choose the larger of the lumens to get you into the sac. So usually once I get into the iliolumbar, I knuckle the wire and I push it. A lot of times it just works well. Similar when you do it with the, plantar artery in the foot.
Totally. When you get that knuckle and it goes, it's so nice. And you briefly touched on endpoint when you're doing transarterial and direct sig. What's your endpoint when you're embolizing?
Yeah, so I try to kind of, at some point as you're filling the sac, you start herniating into the thrombus, and then you can just use a lot of, whether it's liquid embolics or coils are using, and it's not needed. So if, I usually do a cone beam CT to try to kind of see, did I fill the same component that we saw on the delayed venous phase on the CT? If it matches it on CT, then I know I filled the same spot. If I manage to, embolize some of the, outflow arteries and I fill the sac, took most of it. And if I keep injecting, for example, onyx or glue and it starts filling into the thrombus, then I know that there's no reason to inject anymore. So that's usually it's an endpoint. I think that part takes a lot of experience, and be prepared that you think you've done everything you could. You get another scan and you see the area you treated looks great, and then at the edge is another endoleak. You're going to have to go back. It's really hard, regardless of experience you are, to try to get the whole type 2 endoleak, especially if it's a complex one with multiple inflows and outflows. Don't you think I feel like that's the most frustrating?
Agreed. And totally agree with you. I mean, these are the two, like direct stick and transarterial, I would say the two most common ones that we use to treat. I mean, you mentioned earlier transcaval briefly. I mean, do you do many transcaval? I personally have not done a transcaval endoleak, but have you done any?
Yeah, I've done them definitely. And I try to keep them as my backup. If there's a leak that we could not get through it through a transilio-lumbar or treated it and there's still a persistent leak, like I mentioned earlier. And the endoleak is posteriorly medially, so basically adjacent to the cava, then direct sac puncture could happen, but you're going to have to go through the cava. It's probably okay, but that's where the transcaval comes in. You just go and use like a TIPS access needle or transeptal needle and use the sheath, like the ones we use for TIPS to angulate, and then just use it to push through. Again, you don't have as much control of where you enter. So you end up entering a thrombus. You have to kind of pull back till you enter the actual nidus. So I've seen a lot people do it now. There's some study, small scale studies and have an 80% success rate, but I've seen a lot of it done, where you do it and get into the thrombus and they put a bunch of coils and just like none of it is actually in the nidus because you don't have control of where you enter. So I really reserve it for what I just said. It's basically a one-sided endoleak posteriorly that could not get through it through the ilio-lumbar.
When you say you're using the tip sheath, so are you putting a 10 French sheath through the cava into the aortic sac?
Yeah, so basically going from the cava, but no, you don't take the sheath and no, you just only use the transeptal needle through the tip sheath. You can use a Russia sheath needle to give directionality, the metal style of it. And then once you're in, you just advance like a, O&8 V18 wire and then put a microcatheter over it. So the only thing that enters into the sac is a 4 French catheter, but a lot of times catheter is all that you need.
Perfect. And there's no risk of bleeding from the IVC when you take everything out?
No, usually it just seals. And so this transcaval concept has been done, for TVARs and stuff like that, and, for TAVRs as well. Really, they end up using a plug to plug the hole. But for this, if something this small, it's not a big deal. You just have to be careful if you use liquid embolics not to kind of, have anything come back into the cava and then, shoot up. And,
briefly, and then you talked about around the graft or paragraft approach, something we've talked about a little bit online on social media. What is that? What kind of approach is that?
Yeah, I want to hear from you. I've done it rarely. Usually you've done it for when we do some of the chimney work and such. And, basically you go through the iliac limb, but not through the middle of it. You go between the iliac limb and the wall, and you try to sneak a catheter up there to get you into the sac. The main issue becomes that you can enter the sac at a thrombus, not at the nidus. So now you're going to have to find your way back into the nidus. So I struggle with that part. So I'm kind of curious to see your experience with it, because I know you've done it and you liked it.
Yeah, we've been doing several of them lately. Probably now we've done about 18 to 20 paragraphed approaches. And like you said, yeah, you basically, you start off like a transarterial approach. You can do a transarterial at the same time because you access the groin. You pick whatever limb you want to go around, and you literally sneak a catheter, 5 French catheter and wire between the limb and the arterial wall. And in our experience, you would think it'd be very hard to do, but it's almost like just like trying to do a little tiny short segment occlusion, and it goes pretty easily. You're absolutely right. Sometimes, and it's definitely been a couple cases of ours that you just end up in that mural thrombus, and you do a blobogram, and you can try with your catheter. Like I use a Cumpy, and I'll change over to a rim or even a Simmons 1 to try to get some directionality and try to get to a point where I'm getting bleeding back, just like your direct stick or transarterial. But you could get stuck in arterial wall or in mural thrombus, and just that you're not going to go anywhere. But, in several cases, and the majority of the one that we've done, somehow, I don't know, but at the stroke of luck, you get right into the nidus. You do an injection, you see all the, you can see the outflows pretty well. You can roadmap them, use a microcatheter, coil them, and do what you want. And fortunately for us, I'm always surprised we have not had any type 1B endoleaks. We pulling out the system afterwards, the self-expanding limb seals it. But I know you mentioned you had one before where it makes sense if you have a short seal, you might leave a leak there at the end, and then that's not a good thing.
Yeah, I mean, you just have to be careful. You're pushing the graft off the wall, and you just have to be careful that if you already had a tenuous seal in the at the iliac level, that you may need to just coil your way out, or put liquid embolic on the way out. If it's a long seal, then it's not a problem. Usually, it's going to heal on its own. And speaking of coiling or liquid embolic and things like that, it's just there's so many different ways to fill the sac, and everyone had a lot of great success, a lot of series and studies, and it seems like most people have good success. You just have to pick something you're comfortable with. For me personally, I like liquid embolics, and I like to use Onyx is my preferred. I feel I have better control of it than glue. I just know that when I inject it, I know it sticks to the catheter, and I know you have to be patient, very patient with it. I know it's very expensive, and you have to have access to it. If you have to have, work with neurointerventionists and such, and you don't have a problem with that, but some places don't have as much access to it. So for me, I've been lucky to have access to it, and that's my preferred. It's expensive, yes, but I think it's works out pretty well. It causes a lot of streak artifact on follow-up, which is nice. It can obscure a lot of leaks, but it's you can what you treated, where it is, and you kind of look at the edges of it to see if there's a recurrence. So sometimes it's a really big leak, and especially if I did translumbar, then I would I'll just put some big framing coils and fiber coils 035, and I just fill as much as possible. Then I do the liquid embolic to try to kind of fill the crevices in between and try to kind of get into the outflow branches. But, to try to save some of the liquid embolics, I'll use a combination of both, coils and Onyx. What do you use?
Absolutely. I'm more for endoleaks. I am pretty anxious to use glue, especially because you spent all this time to get there, and your microcatheter there. Glue is kind of a one-stop shop, and you got to pull, whereas Onyx, if you put something, you can you have your time, and you just have to be comfortable with it, be patient, but you can do a lot more patiently instead of the kind of quick glue and rip out, And I totally agree with creating a framework of coils and to decrease the liquid embolic, because all of them are very expensive.
I see. I mean, some people have used, thrombin, to add to this. I didn't like it as much because I can't see it, and, it just always worries me. So I think these are, kind of important technologies that you need to be familiar with when you do any of these treatments. And when we mentioned the gutter leak before and some of the others, liquid embolic works very well for these because it can go and can fill the small spaces in between the catheter. But for, a kind of big type 2 endoleak that, you have defined in IMA and such, coils could work well for that. You just put coils in the sac and coil the IMA and get out.
With all these embolics in the sac, it creates a lot of streak artifact, especially if you have coils and Onyx. How do you follow the patients after treating the endoleak?
Yeah, that's the thing about it. Just goes a lot of streak artifact, and joking earlier, you just really cannot see the leak anymore, which is good satisfactory result. The problem is, you have to kind of figure out a way to kind of limit that streak artifact. There's some dual source CTs and such, but for me, I just use a non-con CTM delayed, and despite the fact there's a lot of Onyx creates a lot of artifact, you'll see the leak. If there's a leak outside of the area you treated, you'll see it at the edge. If I have a question, MRI works very well if you have a prior, a lot of coils and Onyx in there. And then you judge by the sac, even if there's a leak or there's no leak. If the sac is not increasing, then I just stop, because that's something that we always struggle with. And I'm going to hear your opinion. If you have a big type 2 leak and then you treat it and there's a really small type 2 leak that is left, just like you missed a small lumbar that is feeding a tiny leak, but the sac is not growing, would you just leave it alone, or would you just say, oh, I didn't treat our leak, let me go back?
I leave it alone. I mean, if it's a big endoleak and it's done, I think I'm like, okay, I'll just watch this and see what happens.
Yeah, I mean, I think that's the thing. I mean, the fact that you treated, you've done the most you could, and there's still a small leak, I would just not get too crazy about it. Try to go chase every single bit of it if you treat the biggest portion. So that's why if the sac size is not changing, the fact that there's a streak artifact, that's not a big deal, to be honest with you. If the sac size is not changing, I would just keep watching it. But if it changes, then, you'll get a better sense. You'll see the leak outside of the, kind of to the side of the streak artifact. We see this all the time.
And then, because that change I was talking about earlier about our MR, our contrast enhanced MR imaging, it's actually a pretty recent change to our policy. And I might start doing a lot more MRA follow-up, for these patients. I've been doing it now for my peripheral vascular disease patients. And, I'll be interested to see whether I get a lot more info or not. And, I'll definitely let you know with that. So just quickly to touch base, we've talked about 1, 2, 3 endoleaks. What do you see type 4 endoleaks often?
No, I mean, I think we're pretty much done. I mean, there's a few grafts in the past that they were too porous and then had issues. So these are, I think, off the market. And similarly, type 5 endoleak, similarly, there's, basically there's no blood in the sac. It's just some fluid. And it's called endotension, and that's pretty much gone. You may see it every now and then from somebody who's still living with some of the older grafts, but I would not worry about these now and just focus on the top 3.
I always thought type 5 was some hocus pocus because it never made sense to me. I read it in books. I haven't seen it personally, but it's good.
I've seen it. I drained it, and it's real. So
really, all right.
You're much, much older than you. So
no, I'm glad to know. I always called it, I called it the idiopathic endotension.
Yeah. It is. It's there. I mean, just put a needle and you just get fluid back. Shooting.
So crazy, interesting.
Pressure. Yeah, but yeah, we don't see it anymore.
Well, any additional comments, anything for our listeners that you want them to know about endoleaks before we end?
Yeah, I mean, I would say that for any young interventional radiologist who has the catheter skills to do all kind of embolizations, and, this is a really nice, challenging procedure to get better at, and you have a lot to offer. I would say partner with your specialists in your area, vascular surgeons and radiologists who, you work with. If you're involved in the EVAR placement, that's great. If you're not involved in the EVAR placement, you can be participant in the aortic program by, providing the skill set that you have with microcath, with, liquid embolics, understanding the imaging interpretation and such to help with the endoleak program. Depending, everything, all politics are local, just, and see what you can offer to the community. Not everyone is in other specialties are comfortable with all aspects of it. Many are excellent at it, but several are, not as much, and they can use your help. So, there's a way, a niche that you can develop, and you have the skills for it. But you need to study, put in the work, and anytime you take on a procedure, you need to know all the ins and outs of it, how to follow the patient, the devices that you're dealing with, and how to treat and follow up these patients yourself.
Great. Well, Saher, thank you so much. That was super informative. I, hope our listeners are excited and learned some stuff about endoleaks. So thank you so much for joining us. Really enjoyed talking to you about this topic, and I hope we can do some more together.
That's awesome. Thanks for being a lot and learn a lot. So hopefully people enjoy listening to this. Thank you.
Absolutely. Absolutely.